Hello, my name is Paul Friedman. I'm chair of the Department of Cardiovascular Medicine in Rochester, Minnesota, and I'm delighted to be joined by my colleague, Dr. Jeremy Thaden, who's an associate professor of medicine and the practice chair for our echocardiography lab. And today we're going to talk about the growing role of interventions for structural heart disease, percutaneous and surgical both. So, Dr. Thaden, Jeremy, thank you for joining me.
Hey, thanks, Paul. It's my pleasure to be here. I'm really passionate about this topic, so I'm happy to be here.
Perfect. Well, let's just start with a very basic level for a broad array of clinicians. Um, Kinds of symptoms and kinds of patients who we may be seeing, who they may think about for interventions, often percutaneous. What symptoms would they have? What would be the lesions to look for?
Yeah, great question. So I also spend a fair amount of my time in the valvular heart disease clinic, seeing these patients. I would say it depends a little bit on the valve lesion. I mean, if we think about aortic valve or mitral valve lesions, left-sided symptoms seem to be a little more predominant. So these patients often early in their course will present with shortness of breath. Patients with aortic stenosis may also present with symptoms of ischemia, so chest discomfort, chest tightness with exertion, or reduced cardiac output. So they may have, pre-syncope or syncope, and in more advanced stages could even have decompensated congestive heart failure. Mitral valve lesions, because it's an upstream valve compared to the aortic valve, often present earlier with heart failure and symptoms of high left atrial pressure. So these patients may present with, again, shortness of breath, left-sided heart failure. And then if we work our way farther upstream to the tricuspid valves, to tricuspid valve lesions, predominantly tricuspid regurgitation, these patients often again have shortness of breath, but they'll often also have more predominant right-sided heart lesions, so or right-sided heart symptoms. So whether that's peripheral edema, sometimes they'll present with symptoms of a high venous pressure in the gut. Reduced appetite, even ascites. These types of things are more common in tricuspid valve regurgitation.
Now, maybe we should start there because, in many ways, the tricuspid therapies are the newest kid on the block. And historically, the treatment would be a diuretic. But we have a lot of new options now. So, how do you approach the evaluation of the patient with serious, severe tricuspid regurgitation? And when do you decide that it's a lesion that warrants an intervention?
Yeah, so this is a great question. So we now have two FDA-approved tricuspid valve devices. So we have an edge-to-edge repair device and a transcatheter replacement device. And then we also have access to a few investigational devices here as well. So the advantage there is that it allows us to treat a variety of pathologies. And I think increasingly in the tricuspid valve space, and then in the mitral space for that matter, we're moving towards a more patient-specific treatment strategy where we're looking closer at anatomy and tailoring the specific device to the specific patient, which is nice. So that's good for patients. But to your question, the first step is figuring out who's going to benefit from therapy. And so um, really the strongest indication for therapy are symptoms. So some of the symptoms we described would be the strongest indication to treat these patients with a device. Um, the second, I think, significant, strong indication would be significant right ventricular remodeling or dysfunction. And so one of the things we're working at very hard here in the valve clinic and as imagers is to better quantify right ventricular size and function. Because when we see the right ventricle start to dilate, decompensate, and decouple from the pulmonary vasculature, we know that these patients don't do as well long term.
Now,
And
just for
so
complete clarity, when you're saying devices, you're really talking about now percutaneous treatment for tricuspid valves, because obviously surgical interventions have been done for eons, most commonly in conjunction with other surgical procedures.
Yeah, thank you for that clarification. So that is absolutely right. So when a patient is referred for tricuspid regurgitation, we think of the whole breadth of therapies and surgery. That includes surgery. So we work in conjunction with our cardiac surgeons and our interventional cardiologists. as a heart team to really help the patients make the best decision for therapy. And so to take a step back, you're absolutely right. Still, the gold standard for treatment for tricuspid valve regurgitation is surgical tricuspid valve repair. And so that really gives the patient the best option to leave the operating room with minimal tricuspid regurgitation. And in the vast majority of cases, they'll keep their own valve, right? It's a repaired valve, and there's good data showing long-term outcomes, durable repair for surgical repair. And what I mentioned previously was kind of the new kid on the block, as you mentioned, which are the transcatheter therapies, which are reserved for symptomatic high-risk patients.
Got it. So before we talk about some of the different valve types of interventions percutaneously, how do you assess, we're focusing a little bit on tricuspid now, but how do you assess whether a tricuspid valve is a bystander lesion versus a primary problem where a repair would help? That is it due to pulmonary hypertension or is it the valve itself? Because often that can be a challenge for the clinician.
Yeah, absolutely true. And so these patients that we're seeing with tricuspid regurgitation, frequently they have other comorbidities. So more often than not, they do. And so I think there is a proportion of patients that will go to right heart cath, and so we'll directly measure the pulmonary pressures, look at pulmonary vascular resistance, and so it's really important to put especially for these tricuspid valve patients to do a comprehensive workup, cast a wide net, and identify those patients where we think tricuspid regurgitation is the predominant lesion causing their symptoms. And so a lot of these patients will end up going to right heart cath to help us tease out how much of this dyspnea is left-sided versus right-sided. And then that also helps us optimize these patients pre-surgically. So even in those patients where, we're still thinking of pursuing a tricuspid valve surgery or tricuspid valve procedure, the right heart cath really helps us to optimize their hemodynamics beforehand. And so we rely quite a bit on an invasive testing for that purpose.
Tell me about the TRIO score or your preferred method of assessing patients as well, where we could get some guides to say, oh, this is one where we really could help. And if we're giving diuretics, we may just be postponing and letting a problem fester and worsen. What are your thoughts on that?
Yeah, so TRIO score is a great score. I mean, I'm biased. It was developed here, but it's a really a nice simple score that was validated in a huge group of patients from here at Mayo that was largely managed non-operatively. And so what they did was they took simple parameters from the chart, some of which were, kidney function, age, LFTs. These are objective parameters that are simple to gather, and they looked at outcomes based on these parameters. And there was about I believe 5 or 7 parameters, something like that. But using these parameters, they were able to risk stratify patients with tricuspid regurgitation. Well, some of these were cardiac related. Some of them were probably not cardiac related. Others, for instance, AST came out as a predictor of mortality, which I suspect is related to liver congestion. So while it's a liver parameter, probably was related to severity of right atrial pressure elevation. And so we can use that score to look at patients and their outcomes. So the higher the score, the worse they do. And so it's a good indicator of patients that we think should really be referred for surgery or transcatheter interventions. And I will say, as a follow-up to that, we also looked at a group of about 500 patients and added quantitative markers of right ventricular function. So the original TRIO score did not have quantitative markers of RV function. But in this follow-up study, we added quantitative markers of our right ventricular function, and that also appears to incrementally improve risk prediction in this group. And so we use a combination of the TRIO score in conjunction with right heart function to help us gauge when patients should go for procedures.
And I'll just add that for those of us who are not valve experts, who will never keep scores in our head, I just Google Trio score, and I know there's a web page where you can type it in, and it's a very simple clinical, really scoring system as you put it out. Um, and yeah, no, it kind of helps us sort out who really should be referred to the valve and structural practice. I have a couple more questions, both about the valve types, but the other questions that come up sometimes is a fair percentage of these patients have atrial fibrillation. And there's this question as to whether we should try to get normal rhythm first versus doing a valve procedure first. And I'd be interested in your thoughts on that because the technologies in both spaces are rapidly changing. On the ablation front, we have pulse field ablation, which is faster, easier, more with a safety profile that makes it more accessible to patients who might not have treated in the past. But the same is true for the valve, where now it's percutaneous. Thoughts on when you would choose one over the other? That is this question of, is the atrial fibrillation causing annular dilatation and tricuspid regurgitation, or is it tricuspid regurgitation causing the AFib? Where to start?
Yeah, these are great questions. So I think this is an area of rapidly expanding knowledge base. I think there are great studies now documenting long-term atrial fibrillation and the risk of worsening tricuspid regurgitation. And ultimately, the majority of the patients that we see for tricuspid regurgitation are functional tricuspid regurgitation, and many of those are atrial functional. And so in my own practice, I have increasingly looked at restoring sinus rhythm as a first step. And in particular, those patients where the timing of onset of persistent AFib, for instance, overlaps with worsening tricuspid regurgitation or worsening symptom status. Because it's very difficult to tease out. If you have a patient who a year and a half ago went from paroxysmal AFib to persistent AFib, we see concurrent worsening of the tricuspid regurgitation and worsening of the symptoms. In my mind, it's very difficult to tease out which is causing which. And so in those patients, I have a very low threshold to refer to your group, to electrophysiology. And what I've seen in my practice is often that these patients will perhaps get an amiodarone load or some type of antiarrhythmic load, and at least a trial at sinus rhythm. So a trial at sinus rhythm with an interval follow-up in 3 to 6 months to see how they're feeling. And I think based on, particularly in studies that have come out recently, showing this correlation between chronic AFib and worsening TR, at least in my practice, I have increasingly looked at restoration of sinus rhythm to see if that helps patients before going the next step, the more invasive step of tricuspid valve repair replacement.
That makes a lot of sense. It really does. And I think we will learn more soon, hopefully, about which one to do first and how to approach these complex patients with multiple interacting pathologies. Now, once the decision is made to perform a, say, transcatheter approach, the patient doesn't otherwise need cardiac surgery or is felt to be high risk for cardiac surgery. Tell us about the kinds of transcatheter approaches and what biases you to pick one versus the other.
Good. Yeah. And so right now we have 2 FDA approved devices. We do have access to investigational devices as well, but perhaps I'll kind of focus on the 2 FDA approved devices now. One is called the TriClip, and that is a tricuspid valve repair device. It's an edge-to-edge repair, meaning we essentially take 2 edges of the tricuspid leaflets and we oppose those to reduce the amount of leakage. The other device is a tricuspid valve replacement. It's called the Evoke valve. And that is simply a replacement device that relies on the annulus and some fixation on the leaflets to provide anchoring for a new bioprosthetic valve. And so each one, I think, has pluses or minuses. I think that the edge-to-edge device, one of the benefits of the edge-to-edge device is it's probably less prone to thrombosis long term. And so with the edge-to-edge device, I think that's one benefit. So in this group, most patients are on anticoagulation, but if you have a patient that's not on anticoagulation or has a contraindication to anticoagulation, probably there's going to be less risk of needing anticoagulation in the future with an edge-to-edge device. We also, I would say, anecdotally have seen less right ventricular dysfunction after edge-to-edge repair as opposed to the replacement device. I think so in patients where there's some degree of pulmonary hypertension or right ventricular dysfunction, it's something that we think about. Now that probably needs more studies to validate that, but it is certainly something that we think about. One of the challenges with edge-to-edge repair with the TriClip is if you have a patient with a pacemaker lead and you think there's significant pacemaker lead impingement, or if the leaflet anatomy doesn't fit for that device, meaning that they're short or significantly tethered, or that there's a large gap between the leaflets, those are some of the anatomic things that might push us towards replacement as opposed to repair. And so replacement, so far the studies would indicate that with the Evoke device, there's probably more complete resolution of the tricuspid regurgitation as opposed to repair. But I think we do see a little bit more RV dysfunction. If the patient's not on anticoagulation, there's probably a little more risk of thrombosis with that valve. So those are some of the ways that we think about individualizing therapy for specific patients.
That's very helpful. And so again, for someone with a pacemaker, you think about replacement. Without it, then maybe it might be the clip, depending on RV function and other considerations. Now, if you're the referring physician, a couple of thoughts. The first one is anticoagulation. Warfarin, DOAC, doesn't matter. And does the choice of clipping versus replacement impact which anticoagulant is used?
Yeah, great question. So a lot, and again, a lot in this space, a lot of the patients with tricuspid regurgitation that are referred are on anticoagulation for different reasons. And so that will likely dictate generally what we do. But there are some that aren't. And so with the TriClip, with the edge-to-edge repair, there's no specific requirement for anticoagulation afterwards. So these patients, if it's only the TriClip or only edge-to-edge repair, they don't need long-term anticoagulation. With the Evoke valve, again, we're kind of early in the experience, but generally, I think the recommendation is at least 3 to 6 months from our practice standpoint, 3 to 6 months of anticoagulation. And typically we use warfarin in these patients. And that's kind of a standard treatment for bioprosthetic, post-bioprosthetic valve in any position in our practice. But I think some of us worry a little bit about the tricuspid position. It's a lower flow system. It's a lower velocity. And so we've seen with surgical valves that they probably are a little bit more prone to thrombosis. And so my suspicion is we may see the same thing as we gain experience with the Evoke, is that it's probably going to be a little bit more prone to thrombosis than, for instance, the mitral side or definitely the aortic side. And so in patients where and we do see these on occasion, where there's a contraindication to anticoagulation, I'm much more likely to consider an edge-to-edge repair if I can do that in those patients, as opposed to a transcatheter tricuspid replacement, where I think there is very likely going to be a longer-term need for anticoagulation.
Now, if a patient is already on Eliquis, we'll say, for example, or some DOAC for atrial fibrillation or another indication, and the decision is made to replace the tricuspid valve as opposed to do an edge-to-edge repair, would you switch them to warfarin or keep them on their current anticoagulant?
Yeah, I would not necessarily switch them. Now, this is, again, another area where I suspect we will learn more as we get more experience with this device, but I wouldn't necessarily switch them. The nice part about this device also is that we're imaging frequently. So we're getting, immediately post-procedure, 30 days, 6 months, and a year at this point. And typically you can see the leaflets reasonably well in the tricuspid position. So even with a careful surface echocardiogram, a transthoracic echocardiogram, you can often see the leaflets. And so the benefit here is that we're screening fairly frequently. So I wouldn't necessarily, in my practice, switch them. But I think if there is any indication of thrombosis at certainly at discharge or 30 days, 6 months, I would have a low threshold to switch them over to warfarin.
So in terms of follow-up care, then you mentioned imaging and then anticoagulation, at least with the valve replacement for 3 to 6 months. Edge to edge may not need it as long, if at all. And then other things for follow-up that the referring physician should be aware for the care of these patients.
I think those are the major things. I think other things are fairly similar to other transcatheter valve procedures. Probably the key point is we are imaging more frequently in these patients, in part because we're sort of following the clinical trial guidelines, intervals for imaging, and it's a relatively new device. And so I think for that reason, we are imaging a little more frequently than other, for instance, TAVR, where we may not do a 6-month echocardiogram.
Sure, sure. And then I'll just add that for patients who have a pacemaker already, we always check them afterwards because it can be disrupted by the valve, obviously. You mentioned imaging, and clearly there's a lot of collaboration between interventional cardiologists and imagers, and imaging is a big part of the procedures. And I think maybe we could just conclude with a little discussion around the team involved in making these procedures happen, these very complex procedures, and any comments you have about imaging before, during, and after. And during, whether you prefer intracardiac echo, transesophageal echo, transthoracic echo, and then imaging before and after the procedure.
Yeah. So the success of these procedures, it's been really interesting being involved in structural heart procedures for now 10 to 15 years. It seems the number of devices and honestly the complexity of the devices is ever expanding, right? So TAVR was kind of the low-hanging fruit. It's a very mature procedure now. LA appendage closure, a very mature procedure. Mitral procedures, when we started doing those, seemed complex, but again, we gained experience, and I think has really developed into a mature procedure. Now, tricuspid procedures are the new kid on the block, and so there is definitely a learning curve, and having an experienced kind of collaborative team that communicates well has been a key to success, because really every member of the team, whether it's the surgeon, the interventional cardiologist, the interventional echo physician, the support staff, all really bring their own expertise to the table. And so having an open conversation and dialogue for procedural planning within the procedure and post-procedural assessment is really key. And so we've seen a lot of these really complex structural procedures. We've seen the imaging actually co-evolve. So that's been pretty interesting. So, 7-10 years ago, we were doing 3D echo, but we couldn't take that three-dimensional volume and really align an infinite number of planes, which is multiplanar reconstruction. We can now do that live, right? So with live imaging, we can take that three-dimensional volume and we can slice and dice it really to see an infinite number of imaging planes. And these tricuspid procedures, it really wouldn't be possible without that, because often the tricuspid valve lies in a plane that it's really difficult to recreate the imaging planes with standard 2D views. And so it's really that 3D echo that has facilitated really the safe performance of these procedures. And so we can now do that by TE, or we can do that with ICE. And I think each of them have their place. So I think 3D TE, its strength is that it's a little bit more in the far field, and so it provides this wide field of view. And so in some patients, and I would say probably for us right now for the tricuspid procedures, probably 75-80% at this point can all be done by TE. Now we see everything well by TE, but there's about probably 20-25% where we can't do the whole thing by TE. We just can't see the images well enough. Or the patient might have a contraindication to tea. They may have esophageal pathology or esophageal resection. And so in those patients, we're relying more on ice or occasionally exclusively on ice. And so I think the benefit of ice is that it doesn't require general anesthesia, but it gives us really high resolution images, particularly of the leaflets and the annulus for tricuspid valve procedures. And so the way that I see these two kind of playing together, they are complementary, where T gives us a little bit wider field of view. We probably don't have quite the same resolution of the tricuspid leaflets, but it's great for a roadmap. So when the device is going in and we're looking at device trajectory and position, T is probably a little bit better because it's in the far field. And then with T, we can often see the leaflets, but when we can't, that's where ice fills in for us. And so that's where ice provides us really high resolution images for grasping or to make sure the device is in the right position. So they're really, really complementary. And we're using, I think, T only, I would estimate probably 75% of the time, in a combination of T ice or occasionally exclusively ice in about 25%.
Fascinating. It's remarkable to see how these technologies really are co-developing. And when you think about what historically had required opening the chest, holding the heart in your hands, repairing a valve versus now imaging from different projections and using percutaneous tools, it is remarkable. But as always, it requires a very specialized team that's tightly coordinated and selecting the right patients for the right procedure. And it is important that a cardiac surgeon is part of the team to determine who's best treated surgically versus percutaneously. And indeed, we have a member of our team who's a fully trained surgeon who's also percutaneously trained who participates in these. So wonderful. Thank you for all the work you're doing and for a very informative session.
Thank you. It was a great conversation. I appreciate it.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Mark Moline, Wound Clinic Director of the Gonda Vascular Center at Mayo Clinic in Rochester, Minnesota. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Head to cveducationmayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses, all created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.